Our lecture today is about fever in the immunocompromised patients. First of all, we have to define the immunocompromised patient or the immunocompromised host. It's the host in which the immune system has failed to protect body adequately from infection due to the absence or insufficiency of some component, process, cell, or substances. Examples of immunocompromised states: congenital immune deficiency. Like many examples, I don't like to go into the details. Some examples are DiGeorge syndrome, Wiskott-Aldrich, combined immune deficiency. Many examples. You don't have to remember them, all of them. HIV infection example. HIV infection when the patient reaches the state of AIDS, which is acquired immune deficiency syndrome, especially at this stage, it will develop immune deficiency and will be supposed to exposed to opportunistic infections, chemotherapy and cytotoxic drugs, immune suppressant medicines including high-dose corticosteroids, metabolic abnormalities such as undernutrition or hyperglycemia in cases of diabetes mellitus, chronic infection like tuberculosis, some acute and chronic viral infections. Some of them can produce immunodeficiency. Next, we have to know what is neutropenic fever, or sometimes it is called febrile neutropenia. It's an important example of fever in the immune-compromised host, and it's defined as neutrophil count of less than 500 cells per cubic millimeter, with a single temperature reading above 38.5 or 3 recordings above 38 over a 12-hour period. Some other references mention it as 24 over a 24-hour period, but according to Davidson, it is mentioned as over 12-hour period. So we'll stick to our reference, which is Davidson. This slide shows some of the immune cells. This is a neutrophil, which is multilobulated. The monocyte, which is this is a neutrophil. This is neutrophil. This is a monocyte. These are some causative organisms. You know the Staphylococcus is gram-positive. This is the gram-positive stain. Pseudomonas, it is a gram-negative. This is a candida, which is fungal infection. How to approach a patient with immune-compromised fever? First of all, we should take detailed history. Every detail in the history should be taken carefully. The history should be repeated daily. Why? Because some symptoms may not appear from the start, may appear in the second or third or fourth day. So it should be repeated until the cause of the infection is known exactly. Identification of the immunosuppressant factors and nature of the immune defects, because some causes produce certain infections or predispose to certain infections, unlike other causes. Systems most likely to be involved, which is respiratory or the GIT or genitourinary system. Any past infections and their treatment. Infections may recur and antimicrobial resistance, and may have been acquired in response to prior therapy, which means if we had a prior urinary tract infections, for example, a previous UTI and a previous treatment with certain antibiotic. If we have a recurrent UTI, recurrent attack of UTI, we may have resistance to the previously used antibiotic, so we must pay attention to this point. Other goals in the history: exposure to infections, including opportunistic infections that wouldn't cause disease in the immune-compromised host. Prophylactic medicines and vaccinations administered. For example, if we are giving a prophylactic medicines, antibiotics such as ciprofloxacin to our patient, we will expect that he is protected to some extent against gram-negative bacteria, unlike gram-positive. And if we are giving an antibiotic which is acting mostly against gram-positive bacteria, we are expecting infection with the gram-negative bacteria. Goals in the examination. Well, in the immune-compromised host or neutropenic patient, some sites in the body has to be examined carefully. Central venous catheters. It is a very important site of infection. We'll cover this subject in the end of the lecture. Canula site for thrombophlebitis, the mouth, the sinuses, the ears, the perianal area. But remember, avoid digital rectal examination because this will administer the infection inside the body. Disseminated infections can manifest as cutaneous lesions. Example, fungal infections will manifest as fungemia. The areas around fingernails and toenails should also be inspected closely. This picture shows thrombophlebitis. This is an inflamed veins. Other goals in the examination. Thorough systemic examination should be done. Respiratory system for signs of pneumonia, nervous system for meningeal signs, abdomen, tenderness, may represent typhlitis or Clostridium difficile infection. Well, typhlitis, it is a case of neutropenic enterocolitis. It occurs especially in the immunocompromised in the neutropenic patient with hematological malignancies. It represents an emergency. Why? Because there is a risk of perforation. It is diagnosed in the CT scan, which will show thickening in the cecal wall. Sometimes it is mistaken for acute appendicitis, so we must pay attention to this infection. Investigations, okay. There are routine investigations. Full blood count with differential, urea and electrolytes, liver function and blood glucose, inflammatory markers, ESR and C-reactive protein, chest X-ray, ECG, urinalysis. These are routine investigations in any neutropenic patient with fever. We must do these investigations. Blood cultures, and if there is a central line or central venous catheter, we should have a culture from the central line. Urine culture, these are routine investigations, but the throat swab, no, it is not routine. Throat swab cultures, sometimes it is done. Stool cultures, especially if there is diarrhea and if the patient has diarrhea. Investigations, other more advanced investigations, chest CT scan, for example, it's only if the patient has respiratory symptoms. Abdominal imaging, well, abdominal ultrasound can be done in any patient, but more advanced like CT, abdominal CT scan, particularly if there is right lower quadrant pain, which may indicate typhlitis, which is, as I said, is inflammation of the cecum in neutropenic patients. Other investigations like nasopharyngeal aspirates are sometimes diagnostic, as an immunocompromised host may shed respiratory viruses for prolonged periods. Other investigations like biopsy of skin lesions, which may represent fungal infections, as we mentioned. All these are more advanced. These are not routinely done investigations, only if they are indicated, if they are suspected. Other useful, we may use molecular techniques like PCR for cytomegalovirus and aspergillus. Antigen assay, cryptococcal antigen for cryptococcal meningitis, Cryptococcus neoformans. Galactomannan test for aspergillus, this means invasive aspergillosis. Or Legionella pneumophila antigen in urine. You have to remember that antibody detection is not useful in immunocompromised patients, as patients may not have adequate antibody production. like for example the antibody test for salmonella or brucellosis. These are antibody-based assay, so they will not be useful in the severely immune-compromised host because we are not expected this patient to produce antibody against these infective agents. Patients with respiratory signs or symptoms should be considered for bronchoscopy in order to obtain bronchoalveolar lavage to detect pathogens including Pneumocystis jirovecii or Pneumocystis carinii, as well as bacteria, fungi, and viruses. Not all patients, as I mentioned. Some patients, when we expect these infective agents, like Pneumocystis pneumoniae, sometimes the X-ray or the CT is suggestive. So the best way to diagnose pneumocystis is by bronchoalveolar lavage and sending it for silver stain. Well, treatment of neutropenic fever. First of all, we have to administer empirical treatment. I think some of you know what is meant by empirical. Empirical means a blind treatment without knowing what is the exact causative organism. I mean, antibiotic is chosen according to the expected organism, according to the environment or according to the predisposing causes. Well, empirical broad-spectrum antimicrobial therapy is commenced as soon as neutropenic fever occurs and cultures have been obtained. Always remember, obtain culture before administering antibiotic. Examples of such regimen are broad-spectrum penicillin such as piperacillin, tazobactam, or meropenem, or cefepime. Well, the doses here are not required. I will not ask you about the doses of the antibiotics. Just know the names of the antibiotics. I think some of you know these antibiotics. Piperacillin is anti-pseudomonal penicillin. Meropenem is carbapenem. Cefepime is a fourth generation cephalosporin. I think you know the antibiotics. Vancomycin should be added if, well, vancomycin is not added to every patient, but there are certain indications for adding vancomycin. Well, what are these indications? Hypotension or severe sepsis, pneumonia, because there may be infection with methicillin-resistant Staphylococcus aureus, or what is abbreviated as MRSA, MRSA, skin infection, or erythema at the site of indwelling catheter, central line, positive blood culture for gram-positive, persistent fever while on empirical antibiotic, history of MRSA infection or colonization, severe mucositis due to quinolone prophylaxis. Quinolone are a group of antibiotics like ciprofloxacin or levofloxacin. If fever has not resolved after 3 to 5 days on empirical antibiotics, and if the patient has been started on empirical antibiotics for 3 to 5 days without improvement, then you have to add antifungal therapy and also empirical antifungal therapy. And the empirical antifungal is caspofungin or amphotericin. Voriconazole if Aspergillus pneumonia is suspected. Well, what is the duration of a treatment? If the fever subsided and returned to normal without finding any source of infection, without obtaining any positive culture, I mean all investigations are normal, then the antibiotics are continued for 5 days after the temperature has returned to normal. But if we have a source of infection, if we have any infection or positive blood culture or positive imaging technique, any infection, we must continue the antibiotics at least 10 days. Prevention, or sometimes it's called prophylaxis. Prophylaxis or prevention are synonymous. First of all, personal hygiene, just like washing hands, using antiseptic techniques, washing hands frequently, topical antiseptic for bathing, and not necessarily antiseptic, just the plain soap, the ordinary soap, it is sufficient. Clean diet and well-cooked food. Avoid undercooked or uncooked food. For example, the raw fruits or raw vegetables are not allowed to eat unless they are peeled. For example, a cucumber or an apple should be peeled or cooked. Chlorhexidine mouthwash, fluoroquinolone antibiotic if neutropenic. We just mentioned fluoroquinolone just like ciprofloxacin. Prophylactic antifungals such as fluconazole. Prophylactic cotrimoxazole for patients at risk for pneumocystis jirovecii. I think I forgot to mention the GM-CSF, which is the granulocyte monophage colony-stimulating factor, or sometimes it's called nepogene, the GM-CSF. Okay, I will write it in the lecture in the Word or PDF that will I provide to you. But remember, the GM-CSF, which is granulocyte monophage colony-stimulating factor, sometimes used as a prophylactic against neutropenic fever. The second subject is central venous catheter infections. Infection of central venous catheter typically involve the catheter lumen and are associated with fever, positive blood cultures, and in some cases, signs of purulence or exudate at the site of infection or site of insertion. Sometimes there are no signs of infection, no redness, no discharge, no erythema, but still there is an infection in that central catheter. Infection is more common in temporary catheters. Unlike the tunneled catheters, there are two types, temporary and tunneled catheters. The temporary catheters are more liable to infection, and inserting into the groin, which means in the femoral vein, is more liable for infection. Tunneled catheters, example the Hickman catheters, may also develop tunnel site infections, but less likely than the temporary catheters. Okay, so what are the more liable lines for infections? They are the temporary catheters and catheters inserted into the femoral vein. You see in this slide, this catheter here, there are no signs of infections, no erythema or no discharge, no swelling. But look at this slide. Here, this is erythema around the site of insertion. What are the causative organisms? Mostly they are Staphylococcus organism. And mostly it is coagulase negative Staphylococcus, more than coagulase positive. I think you know, coagulase negative like Staphylococcus epidermidis, and coagulase positive Staphylococcus aureus. And here in this topic, coagulase negative, which is Staphylococcus epidermidis, occurs more frequently than Staphylococcus aureus. Other causes include enterococci and gram-negative bacilli, and there are other unusual gram-negative organisms, less likely than Staphylococcus. Candida can produce, especially in patients with total parenteral nutrition, non-tuberculous mycobacteria, also may cause central venous catheter infection. Physical examination in bacteremic patients with fever and no other obvious source of infection. Catheter infection is likely. I think we mentioned in the goals in the examination, the neutropenic patient, we have to pay attention, special attention to the central catheters. As I said, there we may have local signs of infection like erythema, purulence, or thrombophlebitis. Investigations, blood culture from the catheter and from the peripheral blood. If the catheter is removed, according to some indications, I will mention it later. If the catheter is removed, then the culture the catheter tip. But if the catheter is retained, is not removed, then we culture the hub. The hub is the proximal end of the catheter. The diagnosis is confirmed if the hub cultures 3 or more folds greater than the peripheral blood. I mean 3 or more colony-stimulating factors. 3 or more the peripheral blood. Well, let me explain it more. We will take 2 cultures from the hub and from the peripheral blood. If the culture of the hub reveals 3 or more folds greater than the peripheral blood, then it is positive. There is positive, considered positive catheter infection. Or if the hub culture turns positive 2 hours prior to the peripheral blood, then it is considered as a positive central catheter infection. Other investigations, well, ultrasound sometimes it can help to detect infected thrombus, and not routine investigation. Others are just the routine investigations like CBC and renal figure. CBC means complete blood count, renal figure. These are routine investigations. Treatment. Well, first of all, you have to decide to remove or to retain the catheter. Catheter removal is indicated if there is severe sepsis, hemodynamic instability, there is metastatic infection like infective endocarditis, for example, if there is suppurative thrombophlebitis with purulent discharge, if blood culture is positive more than 3 days after starting treatment. I mean, if suppose you decided to retain the catheter and started antibiotic, but after 3 days still the patient has positive blood cultures, then you have to remove the catheter. And if there is Staphylococcus aureus or Pseudomonas or fungal or mycoplasma infection, in case of one of these infections, you have to remove the catheter. Empirical treatment, vancomycin. As I mentioned, vancomycin is the drug of choice for Staphylococcus infection. Alone, or sometimes we add a gram-negative cover if the patient has a neutropenia, if there is severe sepsis, if colonized with gram-negative bacteria, or there is, the central line is inserted into the femoral vein. Gram-negative, like ciprofloxacin, like third-generation cephalosporin, like meropenem, all of these antibiotics can cover gram-negative bacteria. Antifungal can be added if the patient is on broad-spectrum antibiotics, if there is more than one site colonized with candida, if there is hematological malignancy, if the patient is on total parenteral nutrition, or if the femoral vein is used for the central venous catheter. The duration of treatment is 14 days, at least 14 days. Staphylococcus aureus. Of long-term catheters, the duration of treatment will be 4 to 6 weeks. In general, in all of these infections, the duration will be at least 14 days. And in case of Staphylococcus aureus, the duration of treatment will be 4 to 6 weeks. Prevention of central venous catheter infection. Well, attention to hand hygiene, Optimal siting, avoid high-risk site of infection such as the femoral vein. Full aseptic technique on insertion and subsequent intervention, and always remember to aspirate before injection. When we use the central catheter, always the first step is to aspirate what fluid is retained in the catheter before injection, before injecting anything, because if we inject directly without aspiration, we will introduce the infection into the bloodstream. Use of skin antiseptics like chlorhexidine or alcohol. Daily examination of the catheter site for signs of infection like erythema or suppuration or discharge. Daily consideration of continuing requirement for catheterization. Whether or you still need the catheter to be kept or whether it is possible to be removed. Should be removed as possible, as early as possible. The use of catheters impregnated with antimicrobials, such as chlorhexidine or silver. In some settings, these catheters are useful. And there's something which is called the vancomycin. Well, the vancomycin, it is a preparation of vancomycin, diluted to some extent. Well, I don't remember the exact dilution, but it is vancomycin and diluted with normal saline and injected in the catheter, in the volume of the catheter itself, like 1 or 2 milliliters, and kept in the catheter. When we use the catheter, first of all, we aspirate this vancomycin preparation and then inject. And we finish, we inject the vancomycin into the catheter and keep it in the catheter for the next time of use. Well, this picture of ultrasound, it shows a thrombus. Here is a thrombus inside the central line. It may be an infected thrombus. And that is the end of our lecture. Thank you.